Good morning, everyone. Tony, are we streaming? All right. Again, good morning. Welcome to the Aging Public Hearing this morning. Does any of my co-chairs or rankings have anything that they want to say? Or we just welcome everybody on our behalf. Thank you for being here. We're going to get right into it. Our first speaker is going to be Commissioner Amy Porter.
Good morning. All set? Okay. Good morning, Senator Hockadell, Representative Garibay, Representative Belinsky, and Representative Fortier, and distinguished members of the Aging Committee. My name is Amy Porter, and I'm the Commissioner for the Department of Aging and Disability Services. For those of you who may not be familiar with our agency, we have 4 major program areas. We have the Bureau of Rehabilitation Services, the Board of Education Services for the Blind, Disability Determination Services, and then we have Aging Services, which is particularly relevant to my testimony here today, as it houses both our state unit on aging and our long-term care ombudsman program, many of whom you see here today. So within the context of this work, I'm here today to provide my strong support of House Bill 5046, an act promoting nursing home resident quality of life. At ADS, we advocate for individuals receiving long-term care services and supports in the settings of their choice. And the collection of measures in this bill will undoubtedly help individuals who are seeking information about our state's long-term care facilities and improve the quality of life for residents in those facilities. In addition, the proposed changes will strengthen our state's long-term care system, rewarding facilities that prioritize quality, person-centered care, and increasing accountability. Many of the provisions of this bill, as you know, will fall under the jurisdiction of our partner agencies in the human service space, particularly the Department of Public Health and the Department of Social Services. So I anticipate that they're going to speak to more of the details of the bill. So I'm going to focus on the impact that we anticipate on our programs and on residents. Those are in the areas of more transparency for those seeking long-term care, improved quality of life for residents of long-term care facilities, and a stronger overall system. So the bill has several provisions to support those who are seeking long-term care. We get a lot of those calls in our office. We get them in our state unit on aging. We get questions in our long-term care ombudsman program. So first, it would improve access to information and increase transparency by establishing an online nursing home dashboard. The dashboard would have comprehensive information on quality care metrics across Connecticut's 200 facilities to allow for informed consumer decision-making. This increased transparency and data access should lead to improvements in overall quality levels as nursing homes seek to improve. The bill also seeks greater transparency in the disclosures provided to residents of assisted living and residential care homes, including information on non-refundable fees and charges, as well as how often those fees may be increased. For residents themselves, the individuals that are living in long-term care settings, the bill seeks to improve the quality of life and quality of care. With a focus on transparency, it would require advance notice of any increase to monthly or recurring fees and full or partial reimbursement of upfront charges under certain circumstances. The bill sunsets 3-bed and 4-bed rooms by fiscal year 27, aligning with the most recent recommendations from CMS to reduce infection risks and protect residents' privacy and dignity. And with the number of nursing facility closures on the rise, the proposed bill seeks to mitigate the negative impact of these closures. The sudden closure of a nursing facility, as you all know, can leave its residents scrambling to find other placements, and in some cases, they may be met with waiting lists for their preferred location. This bill would require that these residents, who face not only losing their home, but their larger network of support, be prioritized on other waiting lists. This can have a significant positive impact on quality of life. You've likely seen the U.S. Surgeon General's advisory, the 2023 advisory on the impact of the loneliness epidemic, which is associated with a greater risk of cardiovascular disease, dementia, stroke, depression, anxiety, and premature death. So this proposed change will help maintain a resident's continuity of care and improve the likelihood that they remain within their chosen community and their support network. The bill also has a number of measures that improve the overall system. The creation of a statewide Center of Excellence designation will incentivize nursing homes to deliver person-centered care consistent with evidence-based practices. We recognize we already have facilities in Connecticut who are consistently providing high-quality care, and we support rewarding their ongoing commitment and performance. We also support expanding the state's authority to hold non-compliant facilities accountable for Connecticut standards, which are often higher than federal requirements. We know it can take time for a facility to get back into full compliance, even after they submit a corrective action plan. So authorizing the state to follow up with these facilities offers technical support to their staff, as well as a level of protection for residents. Another measure to strengthen the overall system deals specifically with the involvement of private equity firms. We've learned a lot about these firms recently, and they're increasingly investing in nursing homes with predictably negative impacts to the health and safety of older adults and people with disabilities. Our testimony includes a link to a 2021 working paper by the National Bureau of Economic Research, which examined 18,000 nursing facilities over a 17-year period, found that private equity ownership had a number of startling outcomes: increased preventable resident deaths by 10%, increased prescription or antipsychotic drugs for residents by 50%, decreased hours of frontline nursing staff by 3%, and increased taxpayer spending per resident by 11%. ADS supports adding several accountability measures for nursing home management companies, including authorizing the state to deny a certificate application or renewal based on past or current disciplinary actions, impose disciplinary actions, including revoking a certificate or imposing civil penalties, and enforcing corrective action plans. The work of our long-term care ombudsman program and our state unit on aging gives me great pride, but also a very real sense of the tremendous needs in our community and in our long-term care settings. The passage of this bill and its proposed measures will improve the opportunity for individuals living in long-term care settings to receive the consistent, high-quality care that they deserve, and it will strengthen our overall system of care here in Connecticut. I want to thank you again for your time and consideration and urge you to support House Bill 5046.
Thank you for your testimony. Do we have questions? Representative Belinsky.
Thank you, Madam Chair. No questions, just my compliments again for your work, and thank you very much for your impact or your reflections on this piece of legislation.
Thank you.
And I will echo that. It's a pleasure working with you. Thank you.
Great. Thank you.
Up next, we have Commissioner Jitani. Good morning, Commissioners.
Good morning, everybody. So good morning, Senator Hockadell, Representative Garibay, Senator Seminara, Representative Belinsky, and esteemed members of the Aging Committee. Thank you for the opportunity to testify in strong support of House Bill 5046, an act promoting nursing home resident quality of life as proposed by Governor Lamont. You have my written testimony before you, but I would like to take this opportunity to highlight some of the important pieces of information from Connecticut nursing home care and key themes that this bill will address today. With me is my Chief of Staff, Adelita Orefici, who also, if I have additional areas of question that you may have, may assist me. So when talking about nursing homes and nursing home policy, we believe, as I know all of you do, that keeping residents and families at the center of all our discussions is of utmost importance. We have 18,000 older adults who live in nursing homes throughout our state. This is, for some people, a place to recover shortly after maybe an illness, and maybe they go home. But for many, this is a place where they eat, they sleep, they live. It is their home. As a granddaughter of somebody who lived in a nursing home, and my grandmother passed away in a nursing home during COVID, I acutely understand the impact that all of what we're talking about has today on patients and their families. Additionally, as a researcher in nursing homes for over 15 years, I have seen with my own eyes the impacts that the pieces of legislation and the authorities that the Department of Public Health, Department of Social Services, and the administration at large have, and how they ultimately impact the lives of citizens and residents of our state. During the pandemic, our nursing homes took an unprecedented hit and toll. They bore a burden more than any other industry in the time of, especially the acute early stages of the COVID pandemic. Many continue to suffer from staffing shortages, inexperienced leadership teams, residents and families who are demanding more person-centered care. And this is when we need to realize that this has to really be a priority. So with these challenges, many of which predated the pandemic, we know that the pandemic only made these challenges worse. So while this bill will not solve all of the problems that we know exist in this industry, it does address three key themes that we need to consider. And those themes include promoting quality of care, protecting consumer rights and choice, and strengthening enforcement of state and federal laws and regulations. So on the first, regarding promoting quality of care, we know that DPH licenses facilities, and without safe, high quality of care, residents will not thrive. They lose their dignity, and Connecticut has many excellent nursing homes, but we need to make sure that the bar is met by all. Consumer rights and choice is equally vital. When people are looking for a home for their loved one, we need to be able to ensure that they have the information at hand to make the decision about where they are entrusting the last days of a loved one's life. And lastly, in terms of strengthening enforcement, at our core, DPH is a regulatory agency. For us to ensure safe care, we need to be able to hold those that are accountable, and we need to be able to have the tools to hold those bad actors accountable. So with that, I'd like to thank the committee for the opportunity to testify before you today, and we are prepared to answer any questions you may have. Thank you.
Thank you so much for your testimony. Do we have questions for the commissioner? Representative Valinsky.
Thank you for being here, Commissioner. And I'm sorry sorry for your loss.
Thank you.
The pandemic was a tough time. I'm coming up on 4 years of the anniversary of my mom's passing in a nursing home facility. So
I'm sorry for your loss.
no, thank you very much. It's but the things that you support in this bill make a lot of sense, because my mom didn't die of COVID. She died of neglect. And that's one of the reasons this is an important issue for me. But I love what you had to say, but as far as the enforcement, what we also call the oversight piece, are you properly resourced? Do you have what you need aside from regulations to endeavor into the actual oversight piece? Because it just seems that that's where we always stub our toe.
Thank you for that question. I think that we know that as a survey agency and as an agency that was hit by the pandemic, just like every other healthcare provider agency in our state, we at one point had up to 40% down in terms of staff in our regulatory piece that we had in terms of staff for that unit. But we are down to only a 14% vacancy right now, and we are getting closer and closer. And so in terms of being fully staffed over the next couple of weeks at this point. So with that, I do think that we will have more and more ability to be able to dig out of the hole that we have been in through COVID because of multiple challenges that have existed. And we have come very, very far from where we were many weeks ago. One of the things that is in this governor's bill is $500,000 of ARPA funds to help us set up a dashboard to be able to both follow quality assurance metrics of nursing homes, but in addition, to be able to be a consumer-facing platform where consumers can actually evaluate nursing homes on that piece. So that infusion of that 500,000 will help us achieve what you're talking about letting us ensure that quality that we need to be able to see occurring in nursing homes. And with appropriated funds that we already have within existing funds that we have, we believe that we can sustain that dashboard going forward. So those are some of the things that are additional commitments in this bill through to DPH that I think will help us accomplish what you're asking about.
Thank you. Thank you for that. That's encouraging to know that that you can sustain something, and it's also encouraging to know that we're not that thanks to the governor, we've got that $500,000 of ARPA money, so we're not going into the budget again. And very important stuff. Thank you very, very much, and thank you for what you've done. You've juggled and kept about 150 balls in the air over the past few years. It's appreciated.
Thank you for your kind words.
Commissioner, ditto to what Rep. Belinsky said, and thank you so much for being here. It looks pretty comprehensive. Is the toolkit full, or is there something missing that needs more looking at for the future? Are there any tools missing in your toolkit? I guess that's the basic way.
I think this bill helps us fill the gaps that we have identified so far. I'm sure in the future, there will be more things that are identified as we start to fix what we know right now based on when we have tried to enforce authority and had difficulty doing that because of some of the gaps that currently exist. So I think this is an excellent first step to help us getting there. This was a very comprehensive effort, an entire all of government approach from the executive branch where we all really came together to put our best ideas forward. But this is a first step.
Thank you for that. And yes, I understand it's a moving piece all the time. There's always improvement, et cetera. Thank you so much.
Thank you.
And thank you, Madam Chair, and thank you, Commissioner. I really heard what popped out to me is promoting person-centered care. Do you believe that with this bill, this is a shift from a kind of what the industry has moved into, which is, you know, much more, you talked a little bit about profit-centered and shareholder-centered and equity-centered into, you know, promoting person-centered care, quality of care, protecting patients' rights, and you just mentioned the consumer-facing piece for families. It's not just the consumer, it's for families that desperately want the best care for their loved one, whether they're on Medicaid, Medicare, or private insurance. Can you talk about that?
Absolutely. Thank you for that question. The concept of a nursing home, and as you said, for families, making the choice is a very challenging one. And our job should be to help people identify a place where somebody is going to feel comfortable that they are potentially removing a loved one from their home and going to a place which is now going to be their new home. It should always be patient and person and family centered. The industry has moved in a way that, as you mentioned, may direct the focus in a way away from the patient and the family. And part of what this bill is doing, and what I so appreciate the leadership of Governor Lamont and the administration, is to raise attention to the fact that the patient, the family is always at the center of what we consider most important in nursing home care. And we, as the regulator of that, are going to ensure with the tools that we have, and that's where I'm here to ask you to help us have the tools we need to ensure that we can get back to that original intent, get back to what we really should be doing when we are helping people make that transition to nursing home care.
Other questions? Because if not, I have one final question for you. So the bill talks about oversight conditions like accountability for management companies and the ability to perform forensic audits and such. Can you describe what some of those circumstances might look like?
So one of the challenges is that when there are financial pressures on a given institution, company, for example, they're not paying their bills or not being able to make payroll, those types of things. We, first of all, don't have that oversight. I'm going to defer to our DSS commissioner who'll be able to answer that question a little bit more in depth. But when those types of problems exist and they're not impacting healthcare quality and safety, which is where our purview is, then there are limited tools. And what we don't want to happen is for something bad to happen to somebody in order to have the ability to go in and intervene. Now, that intervening would be on the side of our sister agency because they have that financial oversight. We have the responsibility of healthcare quality and safety, but when quality and safety is not being impacted, when we send in staff to go and evaluate the state of care, recognizing that this is a fragile host of patients. Many of them have many challenges on a regular basis, but that is part of standard of care in that setting. But if something is not really meeting the threshold of impacting quality and safety, we are very limited. This would now give additional authorities to DSS when there are things like the ability to do a forensic audit or to evaluate when there are financial stressors that are not yet impacting quality of care. So I think that I will let Commissioner Barton Reeves speak to that a little bit more, but from my perspective, I think that is what the major added benefit of that provision is.
Great, thank you. I see no more questions. Oh, go ahead, Dr.
Thank you, Madam Chair. Good morning, everyone. Good morning, Commissioner.
Good morning.
Obviously, as a healthcare worker, I could very easily understand as to what we are facing, in the nursing homes. And this is one of the reasons was, when I first got elected, I wanted to join this committee because I think I could create an impact and to make sure that we are protecting those who are really in need. So with that said, I would like to know, we are talking about quality and safety. I heard you talking about a dashboard. So can you please walk me through the dashboard? Is this in reference to how we collect data? And if that is so, how do we do that? If this is something that is expected to be coming from every nursing home or any specific places? And also, I would like to know as to how do we measure or how do we monitor the quality and safety in the nursing homes? And I ask this question because we are constantly so short of staff. So obviously, this is affecting the quality and safety that we are trying to accomplish. So if you could please answer, I will appreciate it. Thank you.
Absolutely. Thank you for that question. So what this bill would allow is for DPH in consultation with my colleagues who are here today. So our long-term care ombudsman and the long-term care advisory council to develop this online nursing home dashboard. To your question on what is this dashboard going to have, this initiative will then look to work with various stakeholders to identify and collect the information that all of those people identify as important to consumers in terms of identifying how you make an informed decision on which nursing home you might consider that would provide the best care. So it's going to be a collaborative process to identify what are those metrics that consumers might want to be able to look at to identify what the best place might be for their loved one. In addition to that, we know right now that CMS, the federal government, has certain standards that we have to abide by as the state agency tasked by CMS to be the survey agency for the state. So we have been tasked as the survey agency. We meet the CMS standards of quality and safety that are identified, and it's a very robust set of rules, which I'm happy to share with you in more depth if you'd like more information on exactly what the federal government requires. And that is what is in those rules. What we do as a state is say, what are rules that we, as the executive branch, as the legislative body, think are a higher standard for Connecticut that maybe we want to hold nursing homes accountable for? And those are the types of things that when we think about laws that you may pass that say, okay, we're going to be the enforcement agency to say, we're going to ensure that homes meet this standard because we've decided as a state that what the feds have required is not enough, and we want to go a step further. So it's a very lengthy set of regulations that we follow from CMS, but then there are things that are state-specific that we follow as well. So this dashboard is going to be a combination of pieces of information that we collect from that perspective of us as the regulator and surveying agency of homes, plus what consumers feel would be most helpful for them to be able to make an informed decision in terms of where their loved one may stay.
Okay, thank you. I yield. Thank you, Madam Chair.
Thank you. That made me think of one more question. When you're talking about measuring quality, what does that quality look like for you?
So I think that there are a number of different metrics identified specifically on what is quality care, what is safe care. Again, mostly going back to our CMS regulations. And as I've said, this is a very, very lengthy process. And our routine survey aspect of going into homes and being able to identify that they've actually met those pre-identified standards of what quality is defined as is one way. Another way that is done is when there are people who specifically identify that maybe something fell short. And then we go in and investigate those as well. And that's sort of the basic premise of how we ensure that certain metrics that are identified as quality measures are in fact met.
Thank you for that. Senator Rahman is online and has a question for you.
Good morning, Madam Chair. Thank you. Good morning, Commissioner. Thank you for everything you do. We know you are really working hard with this bill, and thanks to the governor actually bringing this thing. So my question to you, I know the last 10 years, so many nursing home and group home closed. 2015, 32 group home closed one day. And since then, a lot of nursing home also closed down, like one is Silverland, Starport, Hartford, South Windsor, and so many others. Do you know why all those group home or nursing home closed?
So thank you for that question. The situation for each nursing home may be different. So you've identified a number of different facilities, and in each circumstance, the situation is unique. What I can say is sometimes it might be at the individual owner's level. They may have challenges, financial challenges. They may have staffing challenges. They may not have enough residents that are in their facility. They may have quality of care issues that have arisen. There may be a decision that it's not in their interest to remain in business in that home. So really the range of reasons that homes have closed is very, very vast, and there's no one answer. What I can say is the fact that we've been through this pandemic, there were so many additional stressors placed on homes related to, as we've already discussed, staffing, but also infection control, way to be able to sustain a staff, be able to ensure quality and safety and financial viability. There's so many additional challenges that have come to homes through the pandemic that we're seeing a host of reasons that various homes have closed.
So second question, I know the our seniors, they want to stay their own home, and but because of one-on-one service is the home care. And the other hand is a nursing home, one employee may be taking care 20 client, 20 seniors over there. Is any way you can identify what is the cost for someone staying the home or apartment complex or is a nursing home? I know that people continue complaining is a nursing home really, really expensive, but there's a 20, client taken care by one employee. Here is the home care is one-on-one service. So why is the nursing home is more expensive than staying in home?
So I'm going to defer most of this to my colleague, Commissioner Barton Reeves, who can really speak to that more in terms of the financing of, those two models of care. I will say that they do have a program, Money Follows the Person, to be able to help people leave nursing homes and go back and live in the community. And part of that is to address the issue that you raised, that it is very expensive to keep somebody in a nursing home versus living at home with supports that can be provided. And so I will defer the rest of that question. I'm sure you can ask Commissioner Barton Reeves as well.
All right, thank you. I really appreciate, but those is the people always coming to us. Hey, I can afford one bedroom. They are paying the rent, utility, everything, but then when go home, the nursing home is more expensive.
That's right.
Even though they are not paying the one-on-one care, is 20 people taking care by one employee. So another thing I want to ask. I know the previous speaker was talking about reducing the employee like 2%, 3% reduction, also pay reduce, so many things they do over there. Is there anything the state taking the action? How you identify, compromise the quality care? How you define the compromised quality care in the nursing home?
Was your question specifically around staffing and reduction of staffing? Is that what you were asking?
Right.
Okay.
Because for that reason, compromise the quality care, because if it's one employee taking care 20 room, it is not been taking care the senior or it should be, because they are rushing like half an hour, clean the room, feeding the breakfast or whatever it is. So reason quality care compromise, not enough employee.
So the state and the legislative body passed a law requiring certain staffing ratios, and we enforce that, to the extent that is the type of policy that is put in place to be able to try to ensure at least a bare minimum of staffing ratio. So that is how we accomplish that goal. Having said that, I hear what you're saying. There are many times we do hear these types of complaints, but we are given the authority to ensure a bare minimum. And so sometimes a bare minimum may not be resulting in an individual patient getting the type of care that they may feel that they deserve.
Well, I thank you kindly. I think this bill will increase the, improving the quality care, and our family could be peaceful in, their own home, and make sure loved one being taken care of the senior in the nursing home. I thank you, and thanks to the governor, and thank you, Madam Chairs, for your hard work and putting all this together. Thanks.
Thank you. Rep. Garabay?
So the pandemic, as we all know, is just like a terrible time in our history, maybe one of the worst. But I also know that nursing homes got ARPA funds, and I know what my district got with R2, and we're talking millions of dollars. And I've been trying, I don't know if anyone out there has a list, I've been trying to get a list of what they did receive in ARPA funds. And do they have to report out how they use those ARPA funds? Because in cases I've heard from, it didn't trickle down to employees or, for direct care to the residents. Can you talk to that at all?
Unfortunately, I don't have that type of information. That doesn't get reported to us. So I would have to defer to OPM, and maybe DSS has some eyes on that as well, but I would have to refer to them.
Okay, I know where to find them. Thank you.
Thank you.
Thank you so much, Commissioner.
Thank you very
Okay,
much
great.
for this opportunity.
And next we will have Commissioner Barton Reeves.
Good morning. Morning. Good morning, Senator Hockedal, Representative Garabay, and distinguished members of the Aging Committee. I am Andrea Barton Reeves, and I'm the Commissioner for the Department of Social Services. I'm pleased to be here before you today in strong support of the Governor's Bill number 5046, House Bill, to strengthen the quality in our nursing homes and to add consumer protections for assisted living residents. As you know, we have an extremely strong interest in making sure that the quality of nursing homes are as high as they can possibly be. And as the state's Medicaid agency, we are the largest payer for nursing home residents, with over 70% of residents covered by Medicaid. You do have our written testimony on Bill 5046 with a focus primarily on sections 11, 12, and 13, but I will just raise some of the highlights here. And then I'm happy to answer any questions that you may have. I also have an entire team of subject matter experts who are always so kind to me and agree to come with me to hearings so that we can answer questions as well. So starting with section 11, this will amend our current general statute, section 17B 99A. And the intent of this amendment is twofold. First, we want to prevent or identify serious financial mismanagement at facilities that may place both state funding and residential health, safety, and well-being at risk. And we would also like some greater financial transparency. And this section of the bill is the one that actually focuses on our ability to conduct forensic audits. The second is section 12, which removes the requirement that a nursing home or residential care home's serious financial loss has to jeopardize the health, safety, and welfare of participants in order for there to be a move to place a nursing home into receivership. And finally, on section 13, this will help us to expand the pool of those that can serve as receivers. Right now, as the statute is currently written, that pool is very small, and essentially you had to have had worked in a nursing home as an administrator in order to serve as a receiver. But as we know, the healthcare industry is quite broad and vast and actually has a number of subject matter experts in healthcare in general that can help to improve and expand the pools of people that would be willing to act as receivers. And we believe that would be in the best interest of the agency, of the industry and of the nursing home residents as well. And so that essentially is the summary of the three sections that we are referring to in section 5046. And so I keep calling it a section in House Bill 5046, and we stand in strong support of the governor's bill, and we're happy to answer any questions that you might have.
Thank you so much. So you heard some of the questions to Commissioner Tajani.
I did.
Especially interested in your thoughts on the forensic audits that you mentioned.
Yes.
When you think those would be, or what conditions would lead you to do those, and how often? Anything you can expand on that?
Certainly, and thank you for the question. Let me start with providing some clarity. The first is that it is our normal practice to conduct audits. We do this with about 60 facilities a year. And the context of that audit is to compare, in many instances, the cost reports and other reports that nursing homes give us as to how they're spending Medicaid and other dollars. We compare that to other financial information they may provide to us, and then we will use that comparison to determine what the next steps will be. There are instances, a few instances, where in the course of conducting those audits, we determine that there may be a bit more that is happening, right? That may be contributing to the financial instability of the organization. And very much, as Commissioner Jutani said, that actually comes to us quite anecdotally. So it may arise as a result of the audit that we conduct, but sometimes we will get a phone call, or maybe the Office of the Ombudsman will get one that says, my health insurance card doesn't work, or, I got a notice that our workers' compensation policies haven't been paid. Or sometimes this happens more often than not, vendors will call and say, you need to know that we haven't been paid in quite some time. And under those circumstances, as the legislation that governs our ability to conduct audits is written, it's very limited for us to be able to do that. We can do a bit more digging, but nursing homes can come back to us and say, under your current purview in your statute, we don't necessarily have to give you all of the things that you're looking for. And so our ability to conduct a very limited extended audit is what we're really struggling with now. So the ability to conduct a forensic audit would allow us to, as we do now, as we would like to do now, is to be able to do a much more extensive look into finances, where we would be able to ask for other records, we may be able to ask for bank statements, we would ask for a list of vendors who may be overdue 30, 60, 90 days. This is the expanse of information that we believe that we would need in order to have a much bigger and more accurate picture of a nursing home's financial circumstances, and then be able to determine what the next right steps would be.
Thank you for that. I'm interested in your thoughts. Is there a way we can better define direct care in this context, so that the public knows that the funds that are going into these nursing homes to direct care are actually going to direct care?
Right. So thank you for the question. There are ways in which direct care is defined, but what I would say is that, and there's always room for improvement, but I would say is that we would also like to have the nursing home facilities have some flexibility around what direct care may mean, depending on who it is that they're supporting and the populations that they're serving. So we can certainly do that, but here is an example of that would be, let's just say, we would say, all right, you know what direct care means, that it's how many times a day that you feed a person or toilet a person. But does that necessarily mean that that meets the needs of one individual, a number of individuals, when maybe it's socialization that's needed, or an opportunity to go out into the community, or an opportunity to sit with someone as they're visiting with their family? So we'd like to give them some flexibility as to how they deliver service, so they can provide the best quality care for the person that's with them. That doesn't mean that we can't work with the industry to help define what that looks like. So there is room to do that. I think the final thing I'll say around that is that we already have a program around acuity of care that we already have in place at the department. And we would like an opportunity to just see how that actually materializes and is implemented by the nursing home industry before we start to try to be more directive. And in many cases, I think they may even perceive it as being a little more restrictive in the ways in which they provide care.
Thank you for that. Questions?
So we have all these tools to find out the information that we need to know what's going on in our nursing homes. But when you find a problem, what do we do? As we saw in the recent newspaper article, the nursing homes owing back taxes to our towns. It's not like a bad restaurant where the food's making people sick. You can close them down and we can't do that with nursing homes. Does this bill help at all in how we hold them accountable? We know what's bad behavior. We've put in statute what's bad behavior, but how do we actually help them to make the changes they need to make?
Yes. So thank you for the question. And we do believe that this bill will help to hold them more accountable. Part of what's in the bill's language is our ability to hold them accountable to pay for the forensic audit. And we understand that there might be some pushback around that, but we are doing that for two reasons. First of all, there needs to be some tool of accountability, and that is one way in which we can do that in this bill. And the second is that the taxpayers are actually carrying the cost for the forensic audit, right? We're carrying the cost for the audits now. So when we do have to dig in more deeply to engage in a forensic audit, we do believe that the way that the statute is written in the governor's bill will allow for that greater degree of transparency and greater degree of accountability.
Good morning, Commissioner.
Good
Thanks for
morning.
being here. I lost one home in my district, and we spoke over the summer, and
Yes.
I appreciate you reaching out and getting back. In your eyes, is there a problem with the Medicaid funding as these group homes shift away from Medicare and the privately funded insurances? It seems to be and I will agree with the senator, there's a major closure in group homes and elderly homes that are affecting us. And the number one complaint that I get, I have another one in my district that's just holding on, and they're asking, hey, if we just get $35 more a day from Medicaid, we could survive. And these are family owned. They're not by any means, I believe, raking in cash. Do you feel that the funding is enough that we give them for these groups to survive when utility costs are doubling and food costs have skyrocketed, gloves, temporary nursing, the amounts they charge are tremendous. Do you
Mhm.
think we are funding them enough to actually survive?
So thank you. That's a complicated question because as you mentioned, that the costs are going up. The Medicaid funding that we've set has been adequate for nursing homes for a bit of time. And we realize that the cost of providing care is in fact going up. For those nursing homes that are facing these pressures, they are in constant communication with us at DSS to determine what their individual circumstances might be. There are some nursing homes that are actually doing quite well financially, and they may have a different payer mix. So that's why I'm not answering the question like, is it more, is it less? Because each nursing home is determining based on the needs of its community and those that they're serving, how they are managing their finances. So some may have a much higher dependency on Medicaid because let's just say, I'll just choose a percentage for the purposes of illustration. Maybe 75 to 80% of their patients are Medicaid patients. And then there are other homes where they may have some private payers, some commercial insurance, some people who are independently wealthy and are also paying. So their dependence on Medicaid is actually quite different than a nursing home that has another mix. So we can always have those conversations with nursing homes that may have a higher population of those that are Medicaid patients as opposed to others to see how we can try to create a better balance for them.
Thank you. So I guess that is my question. You guys do recognize the needs of those homes that have 75, 80% Medicaid patients, and you are willing to work with them or help them?
We're always in conversation with them. Yes.
Okay, thank you.
Yes.
Thank you for that question from my colleague. I also, anticipating going to acuity-based rate reimbursement, how do you think that will address the mix, especially of those that, like my colleague said, are 70% Medicaid residents in terms of viability?
So I may rely on my colleague, Nicole Godburn, who is the expert in acuity, but I will start. And then I'm sure she'll come on and offer more details. But with respect to acuity, the program was designed to encourage nursing homes and nursing home facilities to provide the best and highest quality care for those that have the greatest amount of need. And we've all been in nursing homes. I think most of us have, either through, visits with relatives and the like. And you can see that there may be residents that are actually fairly independent and don't need as much care as other residents that might need all the care that they need for every activity of daily living. So the acuity is designed to be able to sort of ebb and flow and flex depending on that level of care, and really to encourage nursing homes to provide higher qualities of care for those that have higher acuity needs. And that will, in fact, and this is what we're thinking, it will, in fact, it will encourage more of the mix of those who receive care, while also incentivizing better quality care. And I will turn it over to Nicole, who's actually one of the designers of acuity care, so that she can speak to it more directly.
Thank you, Commissioner, and good morning. I'm Nicole Godburn, Director of Reimbursement and Certificate of Need with the Department of Social Services. Quickly, if I may, to touch back on the previous question around when a nursing home says my rate is X and I need more. Just a quick level set, when we launched Acuity 3 years ago, the design of the program was launched to stagger in over 3 years. We wanted the industry to have time to adjust to the acuity reimbursement. We wanted the homes to have that opportunity to start making changes within their facilities, to start accommodating what the resident needs were going to be, and to also allow the state budget time to adapt to the acuity reimbursement methodology. So when a home says that my rate is short, using your example, by $35, part of that reason is because of the mechanism and the guardrails we put in place on the acuity system. Now, come July of this year, those guardrails will be removed, and that was the way that we designed it. So the nursing homes come July will experience their Medicaid rate to fully fluctuate under the acuity system. So if they're experiencing that capping, that was a design that we did purposefully, but that will be removed come July. So to the commissioner's point, when a nursing home takes a resident of a higher acuity need, that person has a much higher resource level. They may need more direct care time. They may need additional supports, additional medical care to meet their need. The acuity system come July will fully fluctuate to recognize that person's need, and the nursing home will see a rate increase in their Medicaid rate to accommodate that person and what their needs are. That adjustment will happen quarterly. So the nursing homes, so it won't be a matter of the nursing home must wait for a year, for example, to see that rate adjust. Those rates will fluctuate quarterly based off of information that the nursing home reports up to the federal government, CMS. They do a data feed up to CMS reporting what their acuity mix is for their residents. That information we will extract quarterly and then recalculate the rates based off their acuity mix.
Thank you.
How is the acuity determined? Is it from the hospital going to the nursing home? Does the nursing home do the testing? Because we've seen some issues with, you know, how they determine if someone has Alzheimer's or dementia. Does that happen with other illnesses?
I love this question. So, as I mentioned, the nursing homes are federally required to report through the MDS, which is the minimum data set. It's a federal requirement that nursing homes must report to CMS. That information that they report up is giving CMS the detail on each of their residents. So that person has a diagnosis of dementia or has a diagnosis of X. That is all recorded in the MDS. Fed up to CMS, we extract it, calculate the rate. But to your question around, is that information accurate? CMS has a bit of an audit process where they're looking at that MDS, and we have a full-blown audit process as well. Our audit process has been going for about a year now, where we have a team of nurses who actually goes into the nursing homes and evaluates the medical records and then cross-checks that to what's reported in the MDS to ensure that that reporting is accurate. Because what you don't want is incorrect information reported and then the rate is fluctuating and it's not reflective of what that resident actually needs. So we do have a whole entire team of nurses who do go out and audit every single nursing home and take a look at the medical record, cross-checking to the MDS. And if we do find errors in that reporting, we do a pretty deep dive into understanding what happened and then putting that home on notice to correct how they're reporting that information.
So what I'm hearing is that the way we diagnose Alzheimer's is different. Because right now in a nursing home, they can ask, you know, questions, not through any rubric, not through the blood test, and they can determine that the person has Alzheimer's. That doesn't happen with other issues is what you're telling me.
So I am not clinical, but there is a standard. There's medicals, and I defer to the doctors in the room. There is a medical standard for diagnosis. And if a nursing home is not following what that standard is for giving someone a diagnosis, that's concerning. And we will catch that on our audit, and we can make those referrals out if additional information, if we need to do a deeper dive.
Okay, thank you. Rep. Polinsky.
Thank you very much. Your testimony is fascinating. Thank you. I don't think there's a person in this room that knew that we were that detailed in how we're forensically auditing. My question is, how often or how many of our nursing home facilities do we audit in any given year? Because it sounds like it's a pretty labor-intensive process that requires an awful lot of reinvestigation to hold people to the standards of care. So I'll just stop the question and ask: what's our frequency, and do we get to everybody, and you know, how often?
Were you referring to the financial forensic audit? Okay,
Yes, Commissioner.
all right.
I am.
Yes.
Because this is
Yes.
I mean, this goes to the heart of all of the arguments that we have here, both the human arguments and the budgetary arguments.
Yes.
So and then it also starts to fiddle around with the fact that everybody's convinced that, we're inadequate in the way that we're funding Medicaid.
Yes, so thank you.
So, I really, really, really would like to hear it from an objective expert.
Mhm.
How frequently are we actually getting a chance to visit this? And then, when we do an audit and have findings, what is the follow-up process to be sure that we've actually taken corrective action where it's necessary?
Yes, all right. I will begin. We actually have the director of our audit unit here today because we didn't anticipate that question might arise. So I'll ask that person to John Jakubowski to join us as well. We conduct about 60 audits a year. So to answer your question, we have a director of the audit department. He has a director that reports to him, and then we have 7 people who are actually conducting the audits. There is a process by which we choose the organizations that we will audit, and there are standards that we apply. They do receive written notice that they will be audited. And we're very specific about the documents that we're looking for, and we use those documents and information in addition to the reports and the cost reports that nursing homes already have to provide to us. The audit is very thorough. I'll have John speak to the details of that. And organizations are entitled, as they are now under the current statute, to have a written detailed description of what we have found and why we feel those are not in compliance with the ways in which we believe they should be handling the finances of the organization with respect to Medicaid dollars and the corrective action plans that we expect them to engage in. And then there is follow-up. They do also have the right to appeal, and they have a right to a hearing. But this is John Jakubowski, who is the director of our audits and quality assurance for the Department of Social Services, and he can answer more detailed questions.
Good morning. As for I think your question is related around forensic audits in general, right?
I'm sorry.
Forensic audits,
Yes.
that's what your
Yeah,
question was
well,
related to?
You guys are finding, commissioners already said that you're auditing 65 homes a year. And she actually took a lot of the answers that I thought we were going to get from you and showed that, that she's totally on top of it too. So I just like to know, the process to make sure that we're remediating where we do find the problems. And not just checking boxes, that's all.
We're definitely not just checking boxes. I appreciate the question. We contract out with a auditing firm for nursing home audits. They do about 55 to 60 per year. And with about 200 nursing homes in the state, they're going to get reviewed once every 4 years. When they go through the audit, there are findings, some severe, some not. The non-severe ones, they'll provide a corrective action plan, and we'll basically follow up with them next time they come up in the cycle. But if we find an auditee, has graver concerns, they can be bumped up in the audit plan, which we do every single year. We have an audit plan with our contractor. They identify which ones they feel should be audited. We have comments, and if we feel that somebody is a perpetual bad auditee, we can bump them up into the audit plan and have them more frequently looked at.
Thank you for that. Thank you for your work. That is fascinating stuff. One other question, if I might, Madam Chair. We have a striated system of, let's call it skilled nursing, let's call it elder care in the state of Connecticut. And I'm sure that most people at home don't understand that when we talk about nursing homes, we're not necessarily talking about the whole spectrum of care. We have a very, very large segment of what we call assisted living. So does any of the audit activity reach that non-Medicaid supported level of care? And if you would comment on, well, let me let you answer the question before we ask for comments. That's a simple question. Do we have a broad enough spectrum to see all of our levels of care and all of our providers in the state of Connecticut?
we primarily review Medicaid dollars when we're looking at
So-
the nursing home audit. So I think that might simply answer the question.
All right, thank you very much. So, okay, thank you. So what we would need to do, as a committee at some point in time is address the standards that you're applying to the Medicaid supported homes across a broader spectrum. Is that? I don't have a question for that. I was going to ask you if that's what I mean. And that's what I mean. So thank you very much. It's a really, really great conversation to have. I appreciate it.
Thank you, Rep. Belinsky. I have Senator Rahman online.
I promise I'm not going to come back again. So thank you, Madam Chair. I have a question to the Commissioner, actually. Good morning, Commissioner. So
morning.
I know, yeah, this bill will help basically sort out all the bad apple, which is very, significant. It's a really great bill. Thank you for supporting. So my question to you, we all know that we have the housing shortage, statewide. Either you're talking the transit-oriented housing, workforce housing, supporting housing, and affordable housing. But here is, what I seen also nursing home. There's a lot of nursing home closed or group home closed. You have a long waiting, people waiting to go home, nursing home. So therefore, or any idea or any plan you have, all the nursing home or group home is closed. Any other way we can reopen, fixing the immediate nursing home room shortage. With that, I have another question. I didn't call how many nursing home we have and how many room we have, and what is the waiting, period now? Thank you.
So thank you for your question. I want to make sure I understand. I think the first question I heard you ask was plans for repurposing closed nursing homes, but specifically to create more capacity in the nursing home industry itself. And
That's
then the
correct.
second, right? So the second that I think I heard you ask was,
So how many nursing home you have and how many room stayed? What is the waiting list now? I know the long waiting, people waiting to go, sign in.
so if you don't mind, I'll ask Nicole to answer the last question first, and then I'll go back and talk about the plan for repurposing closed nursing homes.
Sure. Thank you.
Good morning. Currently, we have around 200 or so nursing homes in the state, but only about 197 of them actually take Medicaid. So as the Medicaid agency, those are the homes that we in particular focus on. But we do have a handful that are private pay, and so that puts the number at about 200 or so. As far as a waiting list, each individual nursing home may have its own waiting list, but currently in the Medicaid portion of the program, we do have about 3,000 open beds or empty beds. So from a Medicaid perspective, we don't see that there's a wait list because we have so many available beds open to our members. But each individual nursing home may have its own wait list, and that wait list could vary for a variety of reasons of how long or short someone may be on that list. So I would have to defer to the industry and to each individual home about the length of time someone may be on a list.
Thank you.
And then relating to your first question about repurposing closed nursing homes, the focus on repurposing closed nursing homes is really a partnership between the Department of Social Services and the Department of Housing. The Commissioner Jatani had testified earlier with respect to the need, or perhaps it was one of the members of the committee, the need for more supportive housing and more assisted living and more types of housing. We do know that we have a severe housing shortage, affordable housing shortage in the state. So the governor's plan is that where there are nursing homes that are currently closed and other facilities that are closed, to work with the Department of Housing and Commissioner Mascaro-Bruno to find ways in which we can repurpose those for affordable housing in the communities. There aren't plans to repurpose those to create more capacity in the nursing home industry itself, but there are plans to use those homes where it's feasible to convert them into housing that is more affordable for all of the workforces that you identified, right? Teachers, first responders, lots of individuals who are serving our community and can't find an affordable place to live in the communities in which they're living and working and serving.
Very good. Yes, I have the bill. I actually introduced a commercial zoning area, all commercial empty property like office building, people working remotely now. So
right.
10 years from now, they will be banding and blighted property. So I introduced the bill to convert from the commercial property to turning to the residential, become affordable housing, will help for our workforce also. So specifically, I was talking about the supporting housing and nursing home. But you answered the question. Thank you, Madam Chair. I appreciate it. I'm not gonna coming back. Thanks.
Thank you, Senator. Are there any other questions?
Thank you, Madam Chair. Thank you, Commissioner. I heard you saying that you are conducted audits on 60 facilities per year.
That's correct.
So how many nursing homes do we actually have
We have
in the state?
we have 200.
200?
Yes.
So does this means then that you are conducting this audits is it like once a year or how often do you conduct them? And I ask this because I'm interested now if we have 200 and if you do 60 per years, then obviously, or perhaps I am wrong, that you are not going into every nursing home conducting these audits. Am I wrong? And also, I would like to know as to whether you also go into assisted living facilities. And are they included within these facilities that you are referring to?
Thank you for the question, Representative. I believe there is a distinction between our role in terms of conducting financial audits, which does not require us to go into the facility, and the roles of the Department of Health and the Office of the Ombudsman that do make periodic visits to nursing homes as part of the regular work that they're tasked under their enabling statute. What we do is we place the nursing homes on a list, as you heard Director Jakubowski say, so that we do audit about 60 of them a year financially, which means they come up really once every 4 years. We make exceptions to that if, for example, as I noted earlier, we do receive reports that there may be some signs of financial instability. And in those instances, we do not wait for them to show up on the schedule. We will step in immediately and determine whether or not an audit is appropriate and add them to the audit list. And in addition, you'll be added to the audit list. Your facility would be added to the audit list based on, you just heard Director Jakubowski say, if the audit that we conduct determines that there are other signs that show that we should be watching that particular facility more closely than once every 4 years, then they will be added to a list so that they may be audited every year or every 2 years. But in our role, we don't make personal visits to, in our financial role, we don't make personal visits to the facilities. That's really done by our sister agencies.
And thank you for your answer. And during their reports, once the audits are done, are you finding now that the monies that you obviously that the state is giving, that we are giving, that what percentage is this being used for direct care?
We're not necessarily measuring which monies are used for direct care. The cost reports, and I will have Nicole Godburn speak to those, ask for a number of criteria. So we do ask for things like staffing ratios, and we do ask for the percentage of dollars that are being spent on administrative costs versus direct care. And so those are some of the numbers that we have, but Nicole, perhaps you can offer some more detail as what we do with our cost reports.
And I will assume that the direct care is obviously, implicates, the staffing, obviously, because I am the direct caregiver. I'm giving the direct care to the patient, which could be either, in the medical or socialization or bathing the patient. So, I am curious as to know, how those monies are being spent. I want to make sure that this money, that we are giving are being used, directly or more for the direct care, which is associated with what I just said, the socialization and therapeutic recreation and, which includes that.
I appreciate this question. So in Connecticut, when we establish the Medicaid rate for a nursing home, we use the cost reports to develop that rate. In Connecticut, we've identified 5 cost components that we feel are very important for reimbursement purposes and running a nursing facility. So when you think of a nursing facility, it's not just direct care, but it's also the food vendors who need to ensure residents have food on the table. It's the kitchen staff, it's your housekeeping, it's your laundry, it's the plumber, it's the maintenance. It's the entire encompassing property plus the direct care that we cover in Medicaid. So there's 5 cost components that go into creating that, and that's direct care, which is usually about 51% of the Medicaid dollar goes to direct care. We also have a category called indirect, that's your housekeeping staff, your maintenance staff, the folks who are important to running your building, but maybe don't necessarily, they're not your nurses, they're not your CNAs. So that's your indirect category. We also have administrative in general, because these are facilities that have payroll staff and other staff who need to run the day-to-day operations. There's also capital. Capital is important to ensuring and making sure that the buildings are maintained. And the last category that we have is what's known as fair rent, because they are properties that have property costs attached to them. So that's the fair rent portion of the rate. So we calculate using the cost reports, we bucket the cost from those cost reports into each of those categories to calculate the rate. There could be a lot of items on a cost report that get reported to us, but we don't necessarily take all of them into consideration because we have to calculate the rate based off of our state plan amendment, which is our agreement with CMS, since Medicaid programs are a 50-50 cost share with our federal counterparts. So we have to calculate the rate based off of what our state plan amendment says, plus our regulations, plus our statute. So there's only certain allowable costs that we are allowed to consider. So there might be a bunch of stuff reported on the cost report, but it doesn't mean that we're going to pay for all of that. But in Connecticut, to your question, about 51% goes to direct care. Now, when costs increase, because we all experience it in our own lives, that the cost of living goes up. So in Connecticut, we have statute that allows us to rebase those rates every 2 to 4 years. So we will be coming up into a rebasing period next year. So and that gives us an opportunity to go back into the cost reports and see if a home has seen increases in staffing, seen an increase in any of those cost centers, and then we will do a rebasing of their rates. Meanwhile, as I mentioned before, the acuity system is riding on top of all of that. So acuity is adjusting quarterly on the direct care component of the rate. And so each quarter, that will adjust up or down based off the care needs of the residents. So if you, again, have a high need resident in your building and you need a higher nursing ratio to care for that person, every quarter that will adjust. So that's how our system is designed, and that's currently what the reimbursement looks like.
Thank you. Thank you, Madam Chair.
Thank you. Any other questions? Seeing none, thank you for your testimony and for answering our questions. Next up, we are going to have Mairead Painter, our state's long-term care ombudsman. You got to change that name. I know it's federal.
Good morning, Senator Hockedal, Representative Garibay, and distinguished members of the Aging Committee. I'm Mairead Painter, the State Long-Term Care Ombudsman, and I want to thank you for the opportunity to testify before you today regarding House Bill 5046, 5120, and Senate Bill 156. House Bill 5046, an act promoting nursing home resident quality of life. I want to express my strong support for this bill as it introduces reforms and improvements to the quality of life for nursing home residents across our state. The legislation ensures that residents receive the care and the respect that they deserve. Regarding the limit to occupancy of rooms, overcrowding in residents' rooms is a common issue that compromises privacy, increases noise level, and exacerbates the spread of infection. We've witnessed how residents in overcrowded rooms experience higher stress levels, reduced quality of sleep, and overall a poor level of well-being. Limiting the room occupancy to no more than 2 beds addresses these concerns and offers residents a more comfortable and dignified environment to live in. I just ask that this is done within attrition and within the requirements related to resident rights and room changes. Regarding Centers for Excellence and that program, the introduction of a Center for Excellence program is an initiative that'll incentivize nursing homes to adopt best practices in person-centered care. By setting evidence-based standards and providing initiatives for compliance, this program could drive improvements in the quality of care delivered to residents, ensuring their needs and preferences are at the center of care planning and service delivery. This program will encourage continuous improvements and innovation in the delivery of services, setting standards of overall excellence in long-term care. Nursing Home Consumer Report Card. I believe that creating an online nursing home consumer resource that accurately reports current data related to the way that facilities are providing care is essential. This will move us towards greater transparency and informed decision-making. Residents and resident representatives often struggle to make decisions in an informed way about how and where to receive care. There's a lack of up-to-date, accessible, and reliable information. The creation of this online consumer resource for each facility will empower residents and their representatives to make informed decisions. It will allow them to make their decisions based on comprehensive data related to the quality of care, helping them choose the facility that best meets their needs. This enhanced transparency will be critical in promoting accountability and driving continuous improvements in care standards across the industry. Enhanced admission and care standards. This will equal access to quality care that is a fundamental right, yet in practice, particularly during a nursing home closure, is not always something that we can ensure. Residents often hope they're fortunate enough to secure a placement in a good facility, demonstrating that there's uncertainty in the quality of care they could receive. There's variability that can lead to significant disparities in health outcomes, as evidenced by research highlighting the severe consequences of nursing home to nursing home transfers. This again demonstrates the necessity of ensuring quality and continuity in care, as well as community integration for all residents. Historically, during a facility closure or other emergency situations, residents often face considerable barriers in securing residencies in other facilities, often resulting in the dislocation from their communities of origin. This dislocation not only is a logistical issue, but is disruptive to their care, severing community ties and distancing them from support networks that bolster their well-being. In my written testimony, you will read findings that 44% of transferred residents experience significant transfer trauma, highlighting the urgent need for policies that mitigate the risks and ensure transitions do not exacerbate vulnerabilities to this population. I believe these protections should extend beyond residents in skilled nursing facilities and also include those in residential care homes, embracing the broader vision of care and support. Through such policies, we can mitigate the risk of transfer trauma and ensure continuity in care and all aspects of dignity and right for residents. Enhancing the quality and compliance measures. The introduction of stringent audit and compliance requirements will enhance accountability across long-term care facilities. I also commend the focus on ensuring institutions are held to account for implementing corrective actions. This way, they will know that deficiencies are addressed efficiently and effectively, leading to an improvement in the quality of care provided. This is something that is currently a challenge. Residents and family members wait for the survey process to take place, and they want accountability. Just to have some facilities not adhere to their plans of correction, reverting to previous practices as soon as DPH isn't looking. To deliver a high-quality healthcare service and successful management, this requirement in certification for nursing home management service providers. With this, we can ensure that only entities with proven records of compliance and quality care oversight are responsible for the overall operations of these facilities. This initiative in particular focuses on the entity's historical performance, scrutinizing the past civil penalties, sanctions, and other methods under Medicare and Medicaid, and for any instance of terminated or non-renewal provider agreements with the federal government programs. This will prevent organizations with histories of significant noncompliance from managing other facilities, thereby prioritizing the safety and quality of care of residents. Enhancements to residential communities brings forth a pivotal enhancement aimed to improving transparency and financial planning for residents. These amendments specifically introduce the necessity for clear written residency agreements to ensure that all services, charges, and rights are comprehensively outlined and easily understood by residents and their families or representatives. These legislative changes collectively aim to bolster the financial transparency and care decision-making process for residents, significantly contributing to their ability to live with dignity and autonomy in a managed residential community environment. Now, HB 5210, an act establishing an elder justice unit within the Division of Criminal Justice. I support this bill as it establishes an elder justice unit within the Chief State's Attorney's Division of Criminal Justice, or for it to be in the most appropriate agency or division that increases positive outcomes and achieves accountability for the individuals we serve. This legislation provides additional attention and strengthens the protections for potential justice for older adults who can sometimes be vulnerable to crimes and exploitation. Now, SB 156, an act requiring nursing home facilities to spend at least 80% of Medicaid funding provided by the state on direct care. I express my overall support for this bill and its goals as the objectives and requirements aim to enhance the quality of care in nursing facilities through mandated allocations of Medicaid funding to direct care. I believe that direct care should be defined only as it encompasses direct hands-on care to individuals and residents as individual residents related to their activities of daily living and on medication administration. The bill works to ensure resources are prioritized for that essential hands-on care and how it directly impacts the well-being and quality of life of nursing home residents. However, I acknowledge the importance of a collaborative approach in refining and implementing these changes, particularly related to indirect care costs and in the context of the fact that Connecticut is going through a transition to acuity-based payment methodology for Medicaid reimbursement in skilled nursing facilities. The bill mandates that skilled nursing facilities spend at least 80% of Medicaid funding received on direct care of residents, while strengthening the minimum requirement for payment allocations to direct care is critical. It is equally important that these changes are made in close consultation with the Department of Social Services. As Connecticut is in the final stages of implementing this new acuity-based payment methodology, there are unique opportunities to ensure that definitions and required payment allocations are aligned with this new framework. DSS's involvement is critical to address the nuances of Connecticut's payment structure, including direct care and indirect care, as well as allowable costs, which may differ from those states that have implemented this, as well as similar requirements. Through continued dialogue, we can identify potential areas for improvement so that we can make informed decisions on the allocation of Medicaid funds, maximizing their impact on resident care. Thank you, and I'm available if you have any questions.
Thank you so much. And I just want to mention, thank you for all the work that you do all year long and keeping us informed in what's going on. So we really appreciate it. Questions for Maureen? Seeing none, thank you so much. We know where you are.
Thank you.
Next up, I'm going to call Senator Martin Looney.
Thank you very much, Madam Chair. Good morning, Senator Hockadell, Representative Garibay, and members of the Aging Committee. I'm Martin Looney, State Senator from the 11th District, representing New Haven and Hamden, and would like to express my support this morning for Senate Bill 156, an act requiring nursing home facilities to spend at least 80% of Medicaid funding provided by the state on direct care. And I would also support expanding this requirement beyond Medicaid and requiring that nursing home facilities spend 80% of their total revenue, including payments from Medicaid, Medicare, and private insurers, as well as from self-pay patients on actual patient care. Other states have already taken similar action. Nursing home facilities in New York must spend 70% of their total revenue, including payments from Medicaid, Medicare, and private insurers on resident care, and at least 40% of that direct care funding must pay for staff members involved in hands-on care. New Jersey's law requires its nursing home facilities to spend at least 90% of revenue on patient care, but it's unclear whether this will be limited to Medicaid funding. In Massachusetts, issued rules requiring nursing home facilities to spend at least 75% of all revenue on residents' care. So I would urge the committee to examine what those three states have already done and to move along those lines with this bill. These requirements are somewhat similar to the federal medical loss ratio requirements on health insurers that require that 80% of premium dollars for small group plans be spent on medical care, and only a maximum of 20% can be spent on administrative costs. And for large group, it's 85% on care and only 15% on administrative costs. So I would urge the committee to support this bill and to include additional transparency requirements on nursing home facilities so that our state and our residents can have confidence in how nursing homes spend their revenue, how they prioritize patient care, so that our families and our nursing home residents can have a greater sense of security and peace of mind. Thank you to the committee and for all the important work that you do year in and year out. Thanks so much.
Thank you so much, Senator. My question we have just heard from our commissioners is we currently only have 51% of Medicaid going to direct care, and going to 80 is a big jump. Do you see this having a huge impact on our home care?
Well, I think it's if the committee in its wisdom decides to move incrementally in that direction, I think that's that may be appropriate. But I think it's important to look at how what the other states have done in getting to that higher number, 70 or 80% or above. And I think it's something that would really help allay some of the fears and anxiety of patients and their families as to the quality of care, the regular attention that they're getting. So if it's necessary to do it incrementally in steps, but I think that should be the ultimate goal to get to that number.
Excellent. Thank you. Other questions, but Representative Bielanski.
Senator, thank you very much for your bill proposal and your testimony. My question is across the spectrum of care. How do we ensure a higher level of direct care at facilities that don't rely on Medicaid funding?
Well, I still think we need to, that's why I would urge going beyond Medicaid and incorporating both Medicare and private pay and private insurance in this as well, as I think at least one or two of the other states have done. So that I think that the committee should look at all of those options and just move in the direction of greater accountability from the nursing homes and making sure that a greater percentage of their overall revenues are pinpointed directly to patient care and direct hands-on care.
Thank you, sir. I appreciate that. We heard a little bit earlier from our in regard to the governor's bill 5046 from Commissioner Barton Reeves and about the oversight being applied, and I asked her this, essentially the same question about private ownership where there isn't Medicaid applied, and I was very, very surprised to learn that we have a pretty robust system of audits, but they only apply to the Medicaid piece. So the accountability is not quite there across the spectrum, and it's something that's sort of an ongoing concern of mine as well. But thank you very much for this concept.
I think, Representative, I think you raise a good point, because it's kind of would be a terrible negative twist if people who are paying more are actually getting less in terms of care coverage and responsiveness to their concerns. If the auditing is only applying to the Medicaid patients, and yet there are so many others who may be paying more and actually having less protection where they reside, I think that's a key issue.
Indeed, indeed. Thank you.
Thank you very much.
Any other questions? Thank you so much, and I'm so grateful for your leadership. Thank you.
Thank you so much, Madam Chair.
Next, we are going to go to Guy Wilson from DSS. He's gone. Okay. Then we're going to go to Jean Mills Arana. And she is online.
Good morning. My name is Jean Mills Arana, and I'm a volunteer attorney with Connecticut Legal Services, where I practice elder law before my retirement. I served on the governor's Nursing Home and Assisted Living Oversight Working Group, which examined solutions to the crises that rose in these facilities during the COVID-19 pandemic. On behalf of Connecticut's legal aid programs and our low-income elderly clients, who include residents of nursing homes, I'm submitting my testimony in support of Senate Bill 156. The purpose of this bill is to require nursing homes to spend 80% of the Medicaid funding they receive on direct care of nursing home residents. This will assure that most of the millions of taxpayer dollars provided to nursing homes is going to fund much needed care and not excessive administrative costs and profits for facilities, their corporate owners, and related entities. Nursing homes frequently complain that they do not have enough funding for the care their resident needs. Yet increasingly they are being purchased by private equity firms who are investing purely to make money from nursing homes. Nursing home residents deserve sufficient care and are entitled to it under federal and state law. By directing a fixed percentage of Medicaid dollars to direct care, we can assure the residents receive this vital care, paid for the taxpayer money intended for this purpose. We support the passage of Senate Bill 156 with some substituted language on 3 issues. With respect to the percentage of Medicaid dollars going to direct care, the language should be clarified to make sure that the 80% of funding going to direct care is calculated based on all Medicaid funding, including federal matches of state funds. And I've suggested language in my written testimony. Secondly, we believe there should be a penalty for failure to comply with this requirement beyond the reduction of reimbursement rate for the facility. We therefore recommend making a failure of nursing home to comply with this provision a Class B violation. Thirdly, we request some additional language to be added to the definition of direct care to make certain that only personnel who are actually providing direct care to residents are counted towards the 80% minimum required. Finally, we also recommend that you address an important transparency issue in nursing home financial reporting. Nursing homes should report profit and loss statement from each related party that has received any amount of income from such facility for goods, services, and fees. Last year, the legislature reduced this threshold for related parties from those receiving over $50,000 per year to those receiving over $30,000 per year. Related parties receiving money should be reported without regard to the amount received. This enhanced level of transparency will enable the state and consumers to understand the nursing facilities financing more fully. To effect this change, we suggest a revision to Section 17B 340 of the statutes, which is attached to my written testimony as attachment 2. Thank you for the opportunity to testify before you today and for your ongoing concern for the rights and care of nursing home facility residents. Happy to answer any questions.
Thank you so much for your testimony. Are there any questions? Seeing none, and I see none online. Thank you again. Have a great day.
Thank you.
I just want to verify Matthew Antoniette and John Jakubowski. I believe they were with the commissioner and have left. Okay, so then we are going to go to Mag Morelli.
Thank you, Senator Hockedal, Representative Garibay, members of the Aging Committee. My name is Meg Morelli, and I'm the president of Leading Age Connecticut, a statewide membership association representing not-for-profit provider organizations serving older adults across the continuum of aging services, including not-for-profit skilled nursing facilities, assisted living communities, and life plan communities. We've submitted testimony on 3 bills before you today, and I will speak on one of those bills, House Bill 5046. Leading Age Connecticut appreciates the governor's midterm budget recommendations regarding nursing homes and assisted living communities, and we're pleased to offer this testimony on House Bill 5056. Much of the bill is directed towards the nursing home sector of the continuum. Nursing homes are an essential element of the long-term services and support system, serving those who are unable to live independently in the community. Because Medicaid is the primary payer for nursing home care, covering 7 out of 10 stays, this creates a partnership between the state and the nursing home sector. As partners, we need to work together to ensure quality and services, and our comments today on the nursing home sections of the bill reflect our commitment to that partnership. I'm going to quickly summarize in my 3 minutes our testimony for you today. We support Section 1 of the bill, which would phase out the 3 and 4 bedded nursing home room configurations in many nursing homes. Many have already moved in this direction. This issue is related to the actual physical plant configuration of the facilities, and therefore we ask that there be some consideration to the resources needed by these buildings to redesign or reconfigure their buildings. Section 2 of the bill proposes that DPH design a voluntary center of excellence model that would incentivize nursing homes to achieve and maintain higher quality, and we strongly support this concept, as it would not only incentivize nursing homes, but also recognize those who are currently providing high-quality care. We support Section 3 of the bill, which would proposes to develop a consumer-facing nursing home dashboard to be housed on the DPH website. While there's a lot of nursing home information available to the public, it's not very easy to access. And because consumers are often challenged by having to choose a nursing home under sudden and very difficult circumstances, we agree that a centralized dashboard of information should be very helpful. We do ask that the wording of the bill be amended and that this dashboard be referred to as a dashboard and not a report card. Section 4 of the bill proposes to facilitate the relocation of nursing home residents when there's a closure. We understand the intent of the bill, but we have concerns with the proposed language. While we appreciate the provision of the bill to protect nursing homes that are at 70% or higher census of Medicaid-funded clients, we ask that language be added to protect a nursing home from being mandated to accept a transferring resident that has no payer source. Section 5, eliminating the rest home with nursing supervision level of care is something that we absolutely support, but we ask that there be language be put in that would empower the agencies to develop an expedited process to do this. Right now, the conversion would require 2 CON requests at DSS and then a new licensure application at DPH. So we believe that we could put in some kind of expedited process. Providing DPH with additional enforcement tools to oversee the plans of corrections that is proposed in 6 and 7. We have no opposition because, quite frankly, we thought DPH already had this authority. Sections 8, 9, I'll be really quick if you let me just go through the rest. Sections 8, 9, and 10, that this is the assisted living pieces. We participated in a work group that was called for in Public Act 2257 that was led by the Ombudsman. This what's in the bill reflects what came out of that work group. We just have one request, and that is that the state demonstration affordable housing sites and the HUD affordable housing assisted living sites be exempt from the new MRC requirements in Section 8 and 9 because it's just a different facility. Section 11, the forensic, this would empower DSS to initiate the forensic audits of the nursing homes and other providers. Now, we have to oppose this section as it's drafted, but we welcome the opportunity for further discussion with the committee and with the proponents. And after hearing the commissioner, I think that they would be very receptive to what our concerns are. Modifying the receivership statutes. We do support these sections, and we ask that Section 12 be expanded even further to allow a qualified entity to be appointed as a receiver as opposed to an individual. This is what happens in other states, and it's very effective in other states. And then we have no objection to Section 14, which calls for more oversight of the management companies. Thank you for the opportunity to provide this very high-level overview of our testimony, and I'd be happy to answer any questions.
Thank you so much for your testimony. Questions?
Thank you, Commissioner. Thank you, Chair, and thank you, Mag. When you say expanded to mean an entity, you mean like a nonprofit organization to be named as the receiver for I don't want to say a failing institution, but
Right. If a nursing home or a nursing home chain were to go into receivership, you need you really need certain qualifications to be able to handle a receivership. And there are entities like corporations, nonprofit entities that can come in as a team and be able to handle the receivership. Of course, a nursing home administrator would have to be running the actual buildings. So this doesn't eliminate the role of the nursing home administrator. It just allows some more flexibility for the court and the state to find someone who's really qualified to handle the level of receivership it might be.
Thank you. And I have another question. You talked about the dashboard being more, less of a report card and more of a dashboard. Would this, the way you perceive the language, would it change My Place CT in that way of a place for mom, or you know, that dashboard that's looking for place?
I don't think so. This would be much more objective. The My
Okay.
Place for Home and the others are people pay to be placed on those dashboards. They're more advertisements. Not that there's not, I mean, there's valuable information. They do consolidate the information. But there are a lot of, you know, there's already a federal report card, the 5-star report that has a lot of information. There's the survey reports that you can get online. You can get them if you walk into a nursing home, they're available to you. The quality measures are out there on Nursing Home Compare. So there's a lot of information, but if you have never considered going to a nursing home before, you have no idea that's out there. So this would be more of a centralized place where you could go as a family member or a consumer to look and see you know, even to find out how many nursing homes are in my area. You might not even know what's available. Also, it would be available to the discharge planners. In hospitals, there's a lot of turnover in discharge planners. That's usually where the decision is made, right there. You know, you're told you've got 24 hours to find out where you're going to place your loved one for their rehab or for long-term placement. And you know, this is the first time you're delving into it. We get a lot of these calls and we try to help people out, tell them how to look for it, what to look for. The 5-star is important. It's not the only thing. There are many reasons why you might drop 1, 2, 3 stars in a quarter or a year, and you're still a very good nursing home. And so this might offer you various sort of measures to look at and just to be able to see as a consumer. It wouldn't be the only place to go, right? And we always say there's nothing that replaces actually visiting the nursing home, but I think it would be a really good, helpful tool for the consumer.
Thank you. And like you say, those discharge planners at the hospital would be key to understanding that this is available to families. But they're not the only sort of care manager, you know, discharge planner. The other thing you mentioned was around the need for more resources, basically, to change the physical plant of 3 and 4 bed nursing homes, which are very old. Can you say something more about the fact that we have not given any resources as a state to new buildings?
Yes.
So therefore, we're creating a, you know, a mandate, if you will, to reduce those room sizes and afford more privacy and so forth, but we haven't built any new facilities.
There's a moratorium on nursing home building, and many people don't realize that. It's been around for maybe 40 years. And so you're not allowed to build a new nursing home except unless you meet one of the exceptions to the moratorium. And you have to go through the CON process. Mosaic Jewish Senior Services in Bridgeport was one of the last ones to be built. It's a beautiful small house model of a nursing home. And but we don't have a lot of those in the state because you cannot build new unless you go through I think a legislative process to be able to build that nursing home. So that's why we have such outdated and old facilities, and they're extremely expensive to renovate because many of them are so old. We have a nursing home right now, one of the newer homes other than Mosaic, which is Livewell in Southington, that's currently undergoing a huge renovation. And, you know, they have to take 30 beds offline to be able to accomplish this renovation. That's 30 beds of revenue that is offline for now, probably 6, 7, 8, 9 months. So it's an extremely expensive venture to be able to renovate a nursing home. Right now, in this current situation we have with building materials and construction and the cost of building, it's also taking a long time to renovate or to build, to get the materials in. It's expensive. So we're asking for people to reconfigure their structure, which makes sense and we support, but we just have to be sensitive to the fact that that means they need to find a place to put those beds, right? They need to create new rooms. They need to separate rooms. They need to work with the Department of Health to make sure that that's all in compliance with the public health code and all of the federal regulations for a new nursing home room. So we're all for it. We just wanted to make the committee realize or recognize that what we're talking about is a physical plant reconfiguration. And that can be very difficult in an older building.
Thank you. And I just want to say that this bill does not deal with the recommendation about heating and cooling in everybody's room, which we did try to address last year. Again, it slams into that wall of the actual physical plant and what it would cost. I think there was a working group around looking at that, but what it would cost to actually provide especially air conditioning in people's
Right.
rooms.
And whether or not, if you're making that huge investment, is that building going to remain that building, right? So we have to look at the use, the length, the extended use of the building before we require somebody to invest a significant amount of money into it, because some of that does come from fair rent and the Medicaid rate that goes into that and the ability to renovate the nursing home. So we really should take a very close look at the infrastructure of our nursing homes and residential care homes throughout the state. Last year, there was an investment in this biennial budget. Time flies. There was an investment in the residential care home physical plant, which was wonderful because they realized we really need to invest in that. And I think we should look at that once the excess bed capacity work group that was put into place last year comes to some conclusions as to what's the right number of beds that we need in this state. And once we come to that number, then we really need to look at, okay, how do we invest and make sure those beds are in high quality buildings, in the right locations? Because with the moratorium came I always say it was like a big ice age. Wherever you were 40 years ago is where you were going to stay in that same building. And that may be, looking back, it may not have been the right choice because our population shifted, as we age in various counties of the state, do we have enough beds? So we're taking a look at that in that excess bed work group. And then once we do that, I think it makes sense to plan ahead as to what we need to do to invest in this sector of the aging services field.
Thank you.
So I have one question. If I understand it, the dashboard is to give the average person out there that's looking for a place for, let's say, their husband to go into, and honey, if you're watching, I'm not thinking of you. But if I'm looking, that I can go to this dashboard, which will be very easy to use, right?
That's what I think that's the concept. This is to hope to sort of to
Right.
develop it, right?
So I'm used to, and dating myself a little bit also, I'm used to looking and seeing 1 to 10, A, B, C, D, F, failure, etc. If we don't have a measurement up there, how is the person supposed to look? It can't be just informational if the purpose is to help the average citizen, because you're right. You said it, they're not going to know to go to DPH and look on there. They're just not going to know those things unless they have help from their senior center or the area's agencies on aging. So if we take away the 5-star, what people normally associate with like a kind of grading system, how will they know? Because I want the 5-star.
Sure. Well, I assume it's going to be linked to 5-star. Because that's what I'm saying. We've already created the 5-star system at the federal level. It gives you a 5 stars. It'll give you your rating, overall rating. It gives you a rating in your staffing, gives you a rating, and then it gives you how you test on various quality measures. And that's already all established at the federal level. It's hard. Sometimes it's hard.
So you're not against the 5-star?
No, what I'm thinking is this dashboard will connect to it and explain it to you. And if this will bring you to their 5-star report. And so it'll bring all of these resources into one area so a consumer can have sort of a one-stop shopping and be able to access all this information rather than us recreating it. I think that would be helpful. Yeah.
Yeah.
And we're actually called for to help in the planning because we're part of the Long-Term Care Advisory Council. And I think that in the planning phase, we can start to think about what else would be helpful to the consumer, right? Maybe it's pictures, maybe it's testimonials, whatever would help, as you said, for the average consumer who's going to this website.
And something they're used to, which the 5-star would be.
Right.
Okay, thank you for that. Are there any further questions? Representative Belinsky.
Thank you very much, Meg, for your work here. Substantial piece of work. I don't have a question, actually. I just wanted to say that, what this committee has become has been, is quite a nice example for world peace, actually. I didn't mean, actually, that just came right out. I don't know if you plan it. But I mean, the way that we collaborate and the way that we listen to each other and all the stakeholders has been pretty remarkable over the past few years. So I just wanted to say thank you for a really thoughtful piece of testimony that actually doesn't just say what we did wrong, but actually tells us how to make it better. So it's an important piece of the work. And I also like the idea of having the dashboard cover
our aging services, and we really appreciate that focus, and we hope that you will consider us as we our aging services, and we really appreciate that focus, and we hope that you will consider us as we sincerely as a partner. We're not always going to like everything, right? We're always not going to agree, but we really appreciate that you listen to us and that you take our opinions into consideration. So thank you.
So thank you very much. And as Rep. Belinsky will call us the dream team, we often have differences also. It's the way we work them out and try to communicate and just try in the end to do what's good for the people of Connecticut. So thank you for all your work.
Thank you.
Right. Okay, this is a remote. It's Irma Rappaport.
Good morning. I'm Irma Rappaport, a national advocate for the Essential Caregivers Movement, and I'm speaking in support of SP 156. One of the biggest issues brought to light by the COVID pandemic, as we have mentioned, has been staff shortages in nursing homes. Low-paying jobs traditionally have high turnover rates, a smaller number of applicants, and less experienced applicants. Statistically, according to Moving Forward Coalition, a national nursing home reform organization, greater than 85% of nursing home residents need help with one or more activities of daily living, such as eating, hygiene, and mobility. The number of residents in nursing home facilities is expected to more than triple by 2050 because of the aging baby boomer generation. Globally, nurses make up 50% of the healthcare workforce. Therefore, this is the time to drastically increase the percentage of Medicaid funding by the government that nursing home facilities are required to spend on direct care to residents by nursing and nursing assistant staff. Direct care is the #1 priority to ensure that residents have high-quality, person-centered care. Most residents statistically don't get regular visitors, so they rely on paid staff to provide companionship and care to them. Direct care should include training. During the pandemic, the training requirements for nursing assistants was lowered in order to get more staff and has been reinstated, but family members have seen deficiencies. Complaints by family members have included the need for more staff training and how to communicate with residents to understand their needs, nursing assistants who don't know how to make a bed, bathe someone, or brush their teeth. One-on-one training is needed rather than just computer training. Separate issue that ties into this is that no family members, ombudsmen, and state surveyors were allowed access to residents for around 2 years or more during the COVID pandemic, and so there was no oversight. I'm helping advocate for the passage as Congress of a federal bill called the Essential Caregivers Act that will allow resident-designated family and friend caregivers access to long-term care residents during a public health emergency while being required to follow the same safety protocols as staff. We must never forget that many thousands of residents in long-term care declined and died during the pandemic from failure to thrive, not from COVID. Families who have been denied access to their loved ones for months and years and who helped give free supplemental care or companionship came back in and saw piles of unopened mail, missing clothing, unused medication, as well as drastic physical and mental decline in their loved ones. Connecticut has passed a state essential support person bill, Public Act 2171, but we also need a federal law ensuring that family ombudsman and state surveyors are always allowed access in order to maintain transparency and accountability in the facility. Even if SB 156, an act requiring nursing home facilities to spend at least 80% of Medicaid funding provided by the state on direct care passes, there must always be outside oversight and advocacy to ensure that it is enforced. Thank you.
Thank you so much for your testimony. Any questions? Rep Hughes.
Thank you so much, Irma. Thank you for your advocacy on a national level. Like you say, we need this across the board, not just in Connecticut. Thank you for your advocacy also in including, I think last year was it, or the year before, in terms of supporting family and caregiver councils to be independently stood up in nursing homes so that family caregivers can discuss concerns about their loved one within that facility. Are you including that in your national advocacy?
Yes, even though my mother is gone, actually, I'm a member of the State Family Council in Connecticut. We have monthly meetings. Mairead Painter was just at our meeting on Tuesday night, and we would like to spread family councils. We would like to know what kind of stigma there is around not wanting to join one. We're trying to figure out the best way to communicate about them and to get as many. You are absolutely correct that advocacy needs a family council so that we can all get together and share our concerns together and not be afraid of retribution.
Thank you. I appreciate your testimony.
Thank you.
Are there any other questions?
Thank you, Madam Chair, and thank you, Irma, also for your testimony. I really love to hear that you are, advocating for a bill at the federal level. I think that the family support, it is so needed because knowing that we are so short of staff all the time, whether it be in a hospital or a nursing home or wherever, a person is in need of medical care, I think it's very important for us to recognize the need of the family support there. During the COVID, it was really sad to see that, we were not allowed to be with those patients who were dying and they were dying alone. So let's take the COVID, as a precedent to recognize the need of having people next to an ill or of somebody who is in need of having somebody with them. I think we as family members of even as neighbors, we are there. We need to be there for our loved ones because many times due to the shortness of staff, those patients are being neglected. There are many times where the patients, the food is sitting right next to them and the food gets cold and they don't have anybody to feed them. So having somebody, with them, I think obviously not only does it help and benefits those who are laying down on that bed, but it is also a big help to us as the healthcare workers, because knowing that we are sure, having an extra head is always very beneficial. So obviously, if at the federal level, at the federal government, something is passed, I think it's going to be a great benefit. And again, just thank you for pushing for that and for being such a great advocate. I yield the floor.
Thank you.
Thank you. Any other comments or questions? Seeing none and seeing none online. Thank you. Have a great.
Thank you.
Next up, we have Michael Warner and Wendy Chang, followed by Daniel Beam.
Good afternoon, Senator Hockadell, Representative Garibay, Senator Seminar, Representative Belinsky, Senator Miller, Representative Fortier, and other distinguished members of the Aging Committee. My name is Michael Warner. I'm the lead aging policy analyst for the Commission on Women, Children, Seniors, equity, and opportunity. And we are here to speak in support of HB 5046 and 5210. I am joined by my commission fellow Wendy Jang, who will introduce herself and testify on HB 5046.
Hello, my name is Wendy. I'm from the Yale School of Public Health. I'm also a fellow at the Palliative Care Center at the Solomon Center at the Yale Law School, as well as a fellow at the commission. And I will begin by elaborating on our support for House Bill 5046 concerning the quality of nursing home in Connecticut, especially sections 1, 2, and 3. And so section 1 stipulates that nursing homes can no longer place residents in rooms with more than 2 beds. This is very important in that it aids infection control as well as promotes the dignity of older adults. And as we move past from the pandemic, it's important that we learn from our mistakes and place as much preventative measures as possible. In addition to that, section 2 raises the Center of Excellence program, which incentivizes nursing homes for good behaviors. Current research actually indicates that penalties in regulating nursing home quality is actually not as effective as we intuitively think. And so we applaud the endeavor in trying to incentivize for good behaviors. And on this note, we would like to suggest that this section of the bill be in consultation with researchers or academic experts to help the program reach its full potential. And lastly, we find ourselves especially in favor of the online nursing home report card, section 3. We think it's a great approach in raising transparency, as well as by involving the stakeholders, including the Long-Term Care Advisory Council, which is administered through our commission. We can aim to bridge the gap between providers and consumer knowledge to try to foster a more open and accountable environment of care. And thank you for your time. I will pass it on to my colleague, Michael.
Thank you very much. And I'm here to speak in favor of HB 5210, an act establishing an elder justice unit in the Division of Criminal Justice. And in addition to my role as the lead aging policy analyst and the Long-Term Care Advisory Council administrator, I also served as the co-chair of the Senior Fraud Task Force. So I want to begin by really expressing appreciation and support of the Division of Criminal Justice. They do a lot of really important work. Our state's attorneys have started a number of new initiatives, including pre-screening initiatives and rolling out a new database. And so we particularly appreciate the work that they do to enforce the law and protect our people. And during the task force, we heard from DCJ about the importance of institutional knowledge and bringing on board the next generation of attorneys and inspectors while the current experienced generation is still on board before they retire. And so one important aspect of this bill would be the need for funding, the importance of funding. This should not be done within available appropriations. They have very high caseloads already, and they're doing a lot with what they have. But we definitely want to make sure that they have that extra support so they can hire new attorneys, new inspectors, and forensic auditors as needed. New Hampshire and Massachusetts each have their own elder justice units. And one of the issues that comes up when we get to the level of prosecution and even other notifications through different mandated reporters is the issue of hesitant witnesses. We know that about 1 in 10 older adults get abused, and we know about 1 in 23, only 1 in 23 do the reporting that's going on. So part of that hesitance comes from, fear of losing their capacity, being, taken out of the community, being put into an institution, not wanting to report on family members. So when we get to that level, when we have to already escalate like that, sometimes it can be a little bit too late, which brings us to the importance of prevention and dealing with it upstream. And so we also applaud this committee for another bill that's coming up, 5001 next week, which helps to expand and support the community ombudsman program. Because the ombudsmen are not mandated reporters, they're able to go into the community and they can have candid conversations. They can see what's going on. They can make sure that the consumer employer knows what their rights are and also like remediate if there's an issue before going up to escalation, as is the decision of the consumer employer. So one potential addition for this topic of adding more staff for DCJ is potentially a grant writer. There might be other opportunities, federal and otherwise, to help support this concept of a dedicated elder justice unit. And so we would perhaps encourage the exploration of that. Thank you for this opportunity to testify before you today.
Thank you so much.
Thank you, Madam Chair, and thank you so much for highlighting this. This is a result of this recommendation for standing up the Elder Justice Unit in the Connecticut State's Attorney's Office. Can you say more? I don't know if you know, but we used to have one, and then we folded it in, sunsetted it because of lack of funding resources. I think we got it stood up with a federal grant through the state. We would like, we're seeking different resources outside of appropriations to stand it up, to seed it, but we will need to look at sustainable funding going forward so it doesn't just go away, because all we are seeing now out of our elder abuse, exploitation, misuse of opioids task force and working groups is the rise of seniors and elders being targeted for abuse, exploitation, scams, financial fraud, and it has catastrophic consequences for those elders, catastrophic in terms of being able to recover, but also live in their homes. So we do know this is going to require, like you said, some institutional knowledge and looking at really how difficult it is to go after folks that are abusing and exploiting elders, and we really need all hands on deck. I'm so glad you mentioned New Hampshire and Massachusetts, who do have an elder justice unit. That was one of the things that came out of our working group, that we need to work in tandem with these other states, because these folks that are targeting, that are going after our elders are very transient. You know, they're not necessarily living in Connecticut. They're out of state actors and looking for the most vulnerable, weakest opportunities to exploit. And we don't want to be that population with our 6 oldest in the state. Can you say something more about working potentially with those other states' units?
Yeah, so first we'll say that I do believe in Massachusetts, for example, it's under their Office of the Attorney General. They have a different constitutional setup, so that Attorney General has both civil and criminal jurisdiction. In Connecticut, the Attorney General only has civil jurisdiction, and the state's attorneys have specifically enumerated in our Constitution criminal jurisdiction. That being said, our Attorney General's office has put forward a great program with the Elder Justice Coalition. There's a hotline that they use. And, I'm reflecting on what you're saying and, potentially maybe if there's some way to incorporate civil penalties that are acquired from other areas that might be able to help fund that. We would have to do a little legal research to see how feasible that might be. But Connecticut has a lot of resources at its disposal, including at the universities. We have, the Department of Administrative Services. We have a lot of really smart people who can do grant writing. So if there's a way that we could encourage cross collaboration and have different dedicated staff grant writers available to go out there and explore and help our agencies who already have really high caseloads, like, for example, protective services for the elderly. That was one of the other issues that came out of our senior fraud task force. We wanted to get them a caseload of about 25 per agent, and that ended up costing 7 million plus per year to be able to do that. That's how intense it is. So that being said, I think there might be other creative ways to do it, but it is very important to just understand that as the currently funded, the Division on Criminal Justice really would need additional funding in order to be able to do this work.
Thank you.
Does anyone else have any questions? Thank you so much for coming today.
Thank you all very much.
Next on the list is Daniel Beam. Oh, he's not? Anna Dorgazi.
Hello. Good afternoon, Representative Garabay, Representative Belinsky, Vice Chairs, ranking members of the committee. My name is Anna Dorgazi. I'm the Associate State Director for Advocacy and Outreach at AARP Connecticut. We've submitted detailed written testimony on all 4 of the items on your agenda today, so I'm just going to briefly touch on our positions on all of those. First, we support House Bill 5209, which would allow for an income tax deduction for long-term care insurance premiums. There are a lot of issues with long-term care insurance products, not the least of which is the fact that premiums are increasing at a rate that is unsustainable for consumers who have spent years investing in these products. This proposal might ultimately be a Band-Aid for a situation that requires surgery, but it would provide some immediate needed relief for consumers who want to maintain their long-term care coverage despite very rapidly increasing rates. Second, we support House Bill 5210, which would create an Elder Justice Unit in the Division of Criminal Justice. Our written testimony shares the story of our volunteer Reggie, who was with me earlier today but had to leave, whose experience of being exploited by a paid caregiver speaks to both the types of crimes that older adults experience and the difficulty that they have in seeking justice once they've been victims of crime. Connecticut's older adult population is going to continue to grow in the coming years, and creating an Elder Justice Unit at DCJ is a positive step toward acknowledging the unique dynamics of the crimes committed against older adults in Connecticut. Finally, there are 2 bills on the agenda today that would impact the 18 to 20,000 individuals who receive care in a Connecticut nursing home each day and who deserve to live in those facilities with dignity. The members of this committee have been leaders in addressing quality of care issues over the past few years, and we support several of the proposals that you've put forward in, you and the governor have put forward in House Bill 5046 and Senate Bill 156. In the governor's bill, House Bill 5046, we support the elimination of 3 and 4 bedrooms, the creation of a Center of Excellence program, the creation of a consumer-facing nursing home report card, and giving DSS the ability to conduct a forensic audit when needed. We have many very good nursing homes in Connecticut, but that last piece about the forensic audits is really critical for identifying and addressing bad actors within the industry. A lot of nursing homes operate under very complicated ownership structures that limit financial transparency and make it difficult to understand exactly how some facilities are spending the billions of dollars of state and federal taxpayer money that they receive each year. Senate Bill 156 would require nursing homes to spend at least 80% of state Medicaid funding on direct care. This idea of a direct care payment ratio is modeled on the medical loss ratios that direct health insurance premiums toward claims and expenses. 6 states have already put similar policies into place. If I may just briefly finish, we understand the concerns about how the definition of direct care in the bill aligns with existing allowable cost categories and how this proposal would impact the transition to the acuity-based payment model. So we'd be open to further conversations with state agencies and other stakeholders about what would need to change in the proposal to make it workable. As I mentioned, we did submit written testimony that goes into more detail, and thank you for the opportunity to be here today.
Thank you so much. Any questions? Representative Belinsky.
Thank you so much for your testimony. Thank you for being here, but most of all, thank you for the incredible advocacy of AARP. And my question is, where are all the people in red shirts?
A lot of them are actually across the street doing a training right now about our fraud watch team. So we're still keeping them busy. That's where Reggie had to go. She had to.
So, yeah, we're accustomed to seeing an army with you, and we appreciate it. So thank you for your insight on the bills, and congratulations.
Great, thank you.
I have one question. Sure. On the elder justice, might be anecdotally, but do we find that the elderly have trouble reporting when do they know when they're even being abused?
You know, I think it depends. I think crime victims sort of across the spectrum, you know, whether it's a sense of shame or stigma, or, you know, for whatever reason, people don't feel comfortable disclosing abuse to the criminal justice system. You know, one of the things we know about different types of elder abuse is that a lot of it is perpetrated by people sort of known and loved to the victims. So I think that can be a barrier to reporting as well. You know, one of my hopes of establishing a dedicated elder justice unit is that they could also engage in some of the education and prevention work that I think would be really helpful, you know, to your point, Representative Garibay, in helping people identify what some of these crimes look like. And you know, what to do when they experience.
Because we don't talk
abuse.
about it a lot. You know, it's not one of those things that's really out there like other types of abuse, right? But I
Mhm.
also find they're afraid, especially if they're in home care or a nursing home, they're afraid it's going to get worse.
Yeah, I think
Like they're
there's
tattling, you know?
Mhm.
Oh.
Yeah, I think there's a fear of retribution. And I think, you know, something that we've heard from AARP members and from our own volunteers is they say, you know, I just feel so silly that I didn't know better. They feel like, you know, I was duped. I fell for something that I shouldn't have fallen for. But that's exactly, I think, the dynamic that folks who perpetrate these crimes are trying to create. They're creating situations where they want to create that sense of shame so that folks don't disclose and they can continue committing these crimes.
So part of all our jobs is to educate people, right? Let them know what does the abuse look like? What do
Yeah.
you do when you feel like you've been abused? Just to have a conversation, et cetera. So thank you very much for coming today.
Great, thank you.
Oh, one more question.
Thank you, Madam Chair. Yeah, right quick. I think I really applaud the idea of creating, you know, this elder justice unit. My concern though comes that many times we don't really recognize when someone is being abused or even when I am being abused. Because sometimes we feel like on a daily basis, because if this is like a repetitive, you know, behavior, we think that when something is being done to us, even though, you know, legally or technically something that could be considered an abuse, we see it as a normal. And I see this even perhaps more, and I could be wrong, within, you know, our communities. Because many times we stay quiet. We do not report either for fears that we may lose the place where we are, or perhaps to protect whoever is, you know, committing what I would call the abuse. The language barrier is also another, you know, issue that we face. First of all, we don't know where we are going to report it. Fears, the language. So there are many elements. So how do we reach out? Or how do we bring in everybody? You know, how do we educate to let people know you are being abused? This is what you could do. Know the signs. And also, I think we need to create venues for different language when an abuse is taking place. Because if you come to me and you ask me questions, you know, you need to bring in somebody that is going to interpret. Because if you're just coming in and asking me the questions, you are not going to be able, you know, to get the right answer for you to identify or to find out as to whether I am being abused. I will not be able to properly report what's going on.
Yeah, and I think, you know, you raise a lot of good points about some of the barriers that come up when it comes to, you know, first of all, the messaging. I think it's so important to, you know, any messaging that's developed around, you know, informing people of what this abuse looks like and how to respond, having it in language. I think that helps people recognize, you know, this is true for me in my community as well, that this resource is available to me, that I think it acknowledges when people are able to access information in their primary language. I think it just resonates in a different way. And I think, if these resources and recourses feel relevant to all communities. I think something abusers count on is targeting communities who don't feel like they have that connection to law enforcement or to our legal system. So I think, any information that could come from the Division of Criminal Justice or from, formal state services that indicate, in their own language, in a way that's presented, that makes sense to their community. I think that tells them, you are deserving of justice in this situation, and here's how you can identify abuse, and here's how you can respond.
Okay, thank you.
Okay, thank you. Thank you, Anne.
Thanks.
Next is remotely Jessica DeRing.
Good morning.
Good morning.
Good morning, members of the Aging Committee. Thank you for the opportunity to testify today. My name is Jessica DeRing. I'm a licensed nursing home administrator, as well as the Director of Operation of Mission Care Health for iCare Health Network in Connecticut. I have been a licensed nursing home administrator for 26 years. I also have served with the Connecticut chapter for American College of Healthcare Administrators on the board for over 20 years, 12 of which on the executive board. I am currently the past president. As I support the bill 5046 in regard to the 3 and 4 bedroom issues and assisting families with identifying quality nursing homes, I would like to oppose the language specifically in the section regarding changing the requirement for a receiver in a Connecticut nursing home from a nursing home facility administrator licensed in the state of Connecticut to a person with substantial experience in the delivery of high quality healthcare services and successful management or operation of long-term care facilities. The reason for this is that as a licensed administrator within a skilled nursing facility, we are responsible for the entire operation of said nursing home. Other qualified persons do not possess the experience of the whole scope of the role and responsibility. As a receiver, it is necessary and appropriate to be able to evaluate the conditions within the SNF, the skilled nursing facility, to determine whether or not it can remain operating or is too far gone to operate, and establish the plan for either scenario to serve the residents and staff of the SNF appropriately. Other disciplines within the industry do not possess the full range of experience that is necessary to maintain the integrity of this process to best serve the residents involved in such matters related to the receivership role. The whole capacity of this operation is not just the financial aspect, but identifying the clinical strengths and weaknesses, balancing the psychosocial needs of the residents, prioritizing person-centered care, physical plant integrity, and that's just touching on the surface. And then having the ability to initiate the quality assurance and performance improvement mechanisms necessary to successfully turn the building around or close it in a safe and effective manner. While at all times, please remembering and respectfully celebrating the rights of the residents and their families. I would please also remember that we are dealing with people's lives and well-being as well as people's livelihood, and this responsibility lies within the licensed nursing home administrator. I would like to say this is my first time testifying and hearing this testimony today. It gives me hope for the long-term care community. I highly respect all those who have testified today from the state level. I've worked with them for years in collaboration with them for years. We are on the same team on this journey, and I look forward to the continued collaboration. I thank you for your time and attention this morning and would be happy to answer any questions you have.
Thank you so much and congratulations on your first testimony. It was excellent. Are there any
Thank you.
Seeing none, we thank you for coming today.
Appreciate it.
The next person is John Baliciano. I hope I said that correctly.
Good afternoon. My name is John Beliciano, and I am a long-term care resident and the president of the resident council at Apple Rehab Hewitt in Shelton. I would like to testify regarding House Bill 5046 that is before you today. I have testified as a member of the statewide coalition of presidents of resident councils for years regarding the quality of care and life as a nursing home resident here in Connecticut. And I would like to provide my strong support for House Bill 5046. When looking at this bill, it appears to me that you were focused closely on residents' rights when you created it. And there are two specific items in this bill I find of incredible importance and would like to speak to. The new minimum limit on resident room occupancy and the creation of an online nursing home report card regarding the new maximum on room occupancy. As a resident of a nursing home, I can't stress enough how vital it is to ensure that our living spaces aren't overcrowded. This is our home. Sharing a room with too many others is more than just an inconvenience. It invades our privacy, increases unnecessary noise, and as we saw during COVID-19, it even increases the risk of getting sick. To limit our rooms to just 2 beds offers us the peace, dignity, and safety we deserve. This change would significantly improve our comfort and overall health. Another item I would like to touch on is the new online report card. Individuals have the right to make an informed choice about what options are out there and where to receive their care. That's why I wholeheartedly support the idea of an online nursing home consumer report card. This online resource would revolutionize how we and our loved ones decide on where to receive our care by providing clear, reliable information about each facility's services and standards. Knowing the staffing levels at each nursing home is especially important to include, as the amount of staff on for a given shift have a direct relationship to whether our daily needs can be met or not. These changes aren't just policies to me. They're about respecting our rights, improving the quality of life, and ensuring we receive the care and dignity we deserve. I have testified here for years about the concerns related to staffing and what it means to us. That's why I am full support of Senate Bill 5046, and I would thank you for your support.
John, thank you so much for coming here today. And in your first comments, when you talked about having too many in a room, I just ask everybody right now to just take 1 minute and think what it would be like if I had to live in a room with 4 different, 3 other people, and what that would be like. So thank you for bringing those comments to us today so that we can really understand some of the challenges. Rep. Belinsky?
John, thank you so much. And thank you for your leadership role on resident councils, which is something that, with advocacy from folks like you, we're seeing a proliferation of people that speak for the rights of others. So thank you. My question is related to what Representative Garabay just said. Living in a room with four, aside from the fact that you don't have privacy and there's a little bit of a dignity issue, I say that tongue in cheek, but what's it like when you have to use the bathroom facility? Because, I mean, can four people fit in there at once?
Well,
It's a loaded question.
Yeah, repeat the question.
I mean, do you ever find that there's a problem when you need to use the restroom facility because you maybe got one or two more folks in line before you?
Oh, most definitely. Because, or even if they need to be changed,
Oh,
that would make it difficult too.
very good. So your testimony is compelling. Thank you for coming. Again, thank you for your role on the resident council. It's so refreshing to get to meet you and tell you that we are working very hard to address your concerns.
Thank you.
Thank you, Madam Chair, and thank you so much for your testimony. It is, how can I describe? I mean, it touches my heart when I hear, directly from the patients, because this is something that I experienced. I work in a hospital where we have, only one room, which is a double. And we experience the challenges that you are expressing on behalf of the members that are not here or could not be here also to testify along with you. I know how difficult it is to share a bathroom, never mind to take a shower. And we are just not talking about that, but we are also talking about such a private, I think it's a violation of HIPAA as well, because many times we are sharing information. So, we are hearing, and even though there may be a curtain around that is protecting me from being exposed for others to see what is being done to me, but my ears are not closed and I could hear everything. So I think this is great. I mean, I am very much opposed to even to a double room. I think everybody should be entitled to have a single room just because of the elements that we are describing here and the deficiencies that it comes along with sharing a room. So I think it's important, and I wish, again, that everybody should just have a single room. If it was up to me, those are the kinds of nursing homes that I will be building for our seniors, for those who are in need, which just take a look. We are getting there. In the near future, we will be using those rooms. And this is why we need more people like you to come out and to advocate, because this is not just for you now, but for the future seniors that are going to be using those facilities. So thank you so much for being here and for your testimony.
Are there any other questions? Seeing none, thank you, John, not only for your advocacy, but for being so brave, and you're living there, you know it, you live it. Thank you very much.
Thank you.
Our last speaker on my list is Matt Barrett.
Hi, good afternoon, Senator Harkadel, Representative Garabay, and to the members of the Aging Committee. My name is Matthew Barrett. I'm President and CEO of the Connecticut Association of Healthcare Facilities, and we're a trade association of skilled nursing facilities and assisted living communities, and I thank you for this opportunity to testify. I'm principally testifying on the governor's bill, House Bill 5046, an act promoting nursing home resident quality of care, and I'll be skipping around in the interest of time regarding certain sections I'd like to highlight, beginning with Section 1. And while we're supportive, we're recommending a number of revisions to this section of the bill. First, because implementation of this section may mean that a nursing home resident could be involuntarily transferred out of the room or even out of the facility, we think an additional protection should be added that would provide the resident with some means to halt or stay implementation of this requirement if the resident objects to being involuntarily transferred. And again, I want to emphasize, I'm not talking about the resident who desires to be transferred out of the room. It's in the instance where a person does not want to be transferred. Second, because a necessary renovation of the facility infrastructure may be required to reconfigure space in compliance with the new rule, we think that a provision should be added that would provide state compensation from the Medicaid program or other resources to cover those unanticipated or additional costs. Third, because in some instances a renovation may not be possible, leaving the only alternative to remove the bed from the facility's licensed bed capacity, we think that a Medicaid rate to adjustment to the facility should be provided in order to compensate the facility for this loss of revenue. And finally, noting that the statewide nursing home occupancy has now risen to 87%. And even pre-pandemic occupancy was in the range of 89%. So very much moving towards pre-pandemic occupancy. We recommend that some kind of access to care analysis be done by the Department of Social Services, similar to the evaluation that do when a licensed bed is being reduced from the facility, or in the case of a nursing home closure, and that the determination of licensed bed need be done prior to the implementation of this requirement, again, on a case-by-case basis. Section 2 and 3, this is the governor's proposed new nursing home center of excellence and nursing home dashboard. We support those provisions, and we're pleased to be named as stakeholder in the development of these proposals, and we're committed to working collaboratively on the implementation of those measures. I would note that the funding seems to be one-time ARPA dollars, and so we're not recommending additional appropriations, but I think we should evaluate the question of whether any additional appropriations for maintenance of these new infrastructures would be needed, or whether or not they're included within the available appropriations of the agency. Section 4. We're recommending that the issues raised in this section be evaluated by the nursing home waitlist work group that convened and made consensus recommendations for adoption this session. However, these additional proposals were not fully evaluated by the work group, and we think the work group could be expeditiously reconvened, and that we could work on achieving a consensus recommendation or fully vetting these additional proposals and make a recommendation before the end of this session. I'd like to skip over to section 11, and I have additional comments concerning the proposed DSS forensic audits. We do think that additional provisions should be added there. We're not opposed to forensic audits, but it's very broad-based language. A facility has no input whatsoever in controlling the costs associated with that audit. And that because it's so open-ended and has potential significant costs, we think that could actually further destabilize a facility that already has been identified as potentially experiencing a serious financial loss. And we're looking for the opportunity to meet with representatives of the Department of Social Services to see if we can work through some of those concerns. But again, not opposed to forensic audits, just have those concerns. Finally, we don't recommend, or not finally, but we don't recommend changing the decades-long standard regarding how a court determines whether or not a receivership should be ordered. There's been a connection between resident care, or the health, welfare, and safety of the resident, and financial stability. We've always believed the statute allowed a determination that even a concern that gave rise to a concern about patient care could trigger the receivership authority. And so I recommended some, I think, maybe friendly an amendment or friendly substitute language on that provision to clarify the rule. Finally, strike that up. Finally, another receivership section. We don't recommend outright eliminating the requirement that a nursing home receiver obtain the qualifications of a nursing home administrator with substantial experience. And so we redrafted that section for your consideration. That would essentially say that in the event that there weren't a sufficient supply
Barrett, can you
of
wrap up,
receivers-
please?
Yep. Just really quickly, Representative Garibay, we just recommended substitute language there that says that in the event that there weren't a sufficient supply of licensed nursing home administrators, that could trigger the additional requirements, which seem reasonable to me, that are recommended by the Department of Social Services. Thank you very much for the opportunity to testify.
Okay, thank you very much. Are there any questions? Mr. Representative Case.
Thank
Mr.
you,
Representative Case.
Thank you, Rep. Garibay. Good afternoon, Mr. Barrett. How are you?
Good afternoon, Representative Case.
Hey, so real quick, you talk about the wait list, and I haven't seen the reports or what came out of the committee. Is the wait list basically workforce driven or beds?
I think I would characterize the wait list as a protection for Medicaid recipients who are awaiting admission to a Connecticut skilled nursing facility. It's been a sort of patient's right or Medicaid residents protection on the books for many years. And it's a whole range of provisions that assure that nursing homes don't engage in discriminatory practices against Medicaid recipients. And so broadly, that's how I would characterize the wait list rules. And I do really respect the work of the long-term care ombudsman over the interim last session, convening a work group that consisted of members of the Department of Public Health and both trade associations concerning updating and reforming some outdated practices related to the wait list. But these are two recommendations that weren't included in there, and I think that they should be vetted by the same work group that just made its recommendations.
All right, I guess I was more asking, do we have a physical wait list on the nursing homes for people that need to go in? And I'm assuring that we have enough beds. Is it a workforce issue? How is the workforce that you're seeing?
Oh, I'm so sorry I misinterpreted your question. I agree. I believe there's actually a direct connection between nursing home admissions, hospital discharges, and the health of the Connecticut nursing home workforce. And while we're moving towards recovery on this side of the pandemic, and by the way, the 87% occupancy figure is kind of an indicator of that. And I think it also suggests that our workforce is starting to sort of recover, but we're just not fully there. And so I see that the workforce issues today, Representative Case, and the inability to hire staff and workforce retention issues continue to be a struggle. And we actually won't get to full occupancy or a much healthier occupancy until those workforce issues are addressed. I hope that's responsive to your question.
Absolutely. And I thank you, Representative, and I'm sure we'll be talking about that some more. But thank you, Mr. Barrett.
Thank you. Anyone else? Thank you, Mr. Barrett. Checking with Tony. Is there anybody else? Okay, seeing none, we will conclude our.
Can I just make an announcement about the testimony?
Sure.
Thanks, Chairman. I just wanted to draw my colleagues' attention to there is some written testimony on from the state's criminal justice department about the establishment of an elder justice unit in the Division of Elder Justice. And I just want to draw your attention to review that, because this is the only hearing we're going to have about that. So let's take that into consideration. Thanks. Thanks,
That's a
Madam
great
Chair.
point. We do have another public hearing next Tuesday at 10 a.m. We'll see some of you there again. And thank you, everybody, for taking the time out to come and talk to us. One last thing. Senator Hockadell is in another important voting meeting. That's why she couldn't come back. And she just wanted everyone to know she didn't skip out.